Hi, I'm Professor Muhammad Moin from King Edward Medical University in Lahore in Pakistan. And today we're going to discuss a very important topic, which is work-based assessment. And in that, we're going to talk about ophthalmology surgical competency rubric. And this we've developed in collaboration with the Ophthalmology Foundation. And I'm really grateful to Professor Carl Gonlick from the University of Cincinnati for working with me and completing it. And let's go through this. What are the goals of an OSKAR? Is to produce a valid and reliable assessment tool for surgical skill and create a behaviorally grounded rubric that will allow teaching and assessing. So if we go to the next slide, does teaching always mean that you've learned? Well, actually, it's not. So that's exactly what we want, that we want to have a rubric through which we can assess that what we have taught or whatever the trainee has learned is actually what was taught, and the learning, is it enough for him to be called competent when he goes out? So if we have the assessment in healthcare professions, you've got 4 levels, and the first 2 levels, knows how and knows are checked by MCQs, essays, and orals, while shows how is checked by OSKI or a long case, but they are all in a simulated environment. The actual real tool which checks an on-place work-based assessment, that is the DOES. And that is what we want to develop, a tool which is so robust that it tells us the real level of competence of the learner. So the trainee assessment can be done with a multiple choice question test, observe patient care, observe surgical procedural skill, or a 360-degree multi-source feedback. So those are the different things which we always do in a trainee assessment. So what is different in WPBA and DOPS? So if we take this, the work-based assessment, this College of Physician and Surgeon in Pakistan, they've got developed a very good standard tool, which is probably prevalent in other systems as well, that you have the assessor, the resident name, the hospital, then the year of residency, the name of the procedure, the complexity of the procedure. This just gives you an overview, what are you checking and what level of training that the resident is. And then next you go into the procedure. So you sit in with the procedure with the resident and you ask him to perform the procedure with the steps, which include, he tells the indications, he takes informed consent, he prepares for the procedure, use of anesthesia, observation of asepsis, and then the safe use of instrument, use of accepted techniques, management of unexpected events, professionalism, and post-procedure instructions, and overall ability to perform the procedure. They are all checked in this, and they're graded according to not observed or good or bad or excellent. Then you sit back with the trainer and you ask him, what do you think his shortcomings are? And then you tell him that these are the shortcomings which you felt, and this is how you can improve. And then if he passes that DOPS at that level, he goes on to the next one. But if he does not, he can always sit back and sort of come back again. So it acts as a formative assessment to improve his skill until he becomes competent. So that is direct observation of procedural skill. But do you think, is there any way, if there are multiple assessors, can they give the same result? Because the columns are empty over here. So every assessor might have a different understanding of a good or an excellent or a satisfactory. But if you put behaviorally anchored or answers in these, or the expected skills which he needs to have in these columns, then obviously it becomes much more reliable. Reliability would mean that if another person or 3 or 4 assessors are assessing the same thing, they will eventually get the similar results, which is so important to remove the bias, which the trainee was always say that I got a difficult examiner, that's why I didn't pass this. So this is something which they use at the Cincinnati Eye Institute. This is just a skill assessment checklist. So this is for tonometry, accuracy obtain IOP readings by applanation. They just say yes, no, observed, not applicable, or refractometry. So it is not behaviorally anchored. So yes, it tells you that he can do it, but does not tell that what level can he do it up to. So that is very important to know which level the trainee can do the procedure. Then you go on what is a rubric, an explicit set of criteria used for assessing a particular type of work or performance. So it consists of dimensions, which are the steps of the surgical procedure, which are given in the first column. And then you come on to the top row, which is the levels, which gives you to novice to expert and also include being a competent person. And then you've got the descriptors, which are the precise behavior for each level, which are present in the boxes below the levels and in front of the dimensions, which we'll show you next. So here we made an OSKAR, which is pterygium split into 18 steps, dimensions, level, and descriptors. So the first one is the component placement of a speculum and draping. The second is a limbal corneal traction application. Then you go on to the levels, which are the novice, beginner, advanced, beginner. And then you go on to the descriptor. Is it difficult to place the speculum or not? So those are the things which you come. Then we go on to what is a Dreyfus model of skill acquisition. There are stages of competence. I think everybody knows that, but you don't have it on paper that whenever we learned bicycling or learned to drive the car, we started out from a novice. We had like a bicycle which had 4 wheels. We couldn't fall off it. Then we came on to a 2-wheeler, but we need sort of side wheels to support ourselves so we don't fall down and keep the balance. Then we went on to an advanced beginner in which we were able to ride the bicycle, but we were a bit shaky sometimes, but without the 2 extra wheels. Then we became proficient. Then we could go in and ride the bicycle in a park, on a road, and that made us more proficient. And then the last step is going to an expert level. Not everyone reaches the stage in which probably you go and compete in a race. That is the most level of expert. So it's very important to understand that what we want out of a resident is to make them competent so he can go in and do the routine procedures. We don't want him to be #1 vitreoretinal surgeon in the town. That's not what you can achieve in 4 years of training. So the OSKAR process is how we make it. International panel of experts first create a draft. The draft is revised on Google Docs. And then final draft is sent to international panel for comment. And then the panel comments are incorporated. So everything, the descriptors are all modified. The steps and the levels are all modified. So the other OSKAR available, been published, which includes the cataract surgery, pediatric cataract surgery, on oculoplastic, then on corneal surgery, and they just published our Open Globe, Pterygium, and Tube Shunt. So I'm one of the authors in the Open Globe OSKAR as well. I'm the lead author in this Ophthalmology Foundation rubric on Pterygium. So what are the implementation tips? Evaluators, formative feedback is teaching. 360 is anonymity, is crucial. Purpose is to make better doctors. For the residents, the purpose is to help you and to provide more specific and precise feedback, because the residents should not feel that it's a burden on them. So convince the residents that it's up to their benefits, have it available in the clinic or the operating room, and the residents ask the teachers that, please, today is my day, you're going to do DOPS with me, or an OSKAR with me, and you're going to sit through the procedure and give me feedback. So the surgical, so it attempts to assessment objectively, helps assessor with specific examples, tells what is expected, provides opportunity for a prompt and easy feedback and a structured feedback. But the resident should know with this form, it's not that it is given to him on the day he's going to be assessed. You give in before. He knows about it. It's there at the start of the training. This is how when you're going to learn pterygium surgery, this is what is going to be assessed, and this is what you're going to do. So this is how it works. So this is the original article which we published, and this is the background and the methods. A panel of 5 experts consisting of members from different regions, including Pakistan, United States, Iran, Mongolia, and Peru, were formed to create a rubric. And then it was using the standard template, using the previous OSKARs, and the rubric was designed using the Dreyfus model of skill acquisition, and then 13 essential steps in pterygium surgery and 5 global indices. Can you focus the microscope? Are you able to have good hand coordination? And we found that it has got a good face validity and can be used effectively for both teaching and assessing ophthalmology residents across programs in the world, because it's objective so that you can easily assessed by different examiners, and it gives you a good inter-rater reliability. And here you can see, this is the thing which you see we're giving injection for pterygium surgery. And here you can see marking for pterygium surgery. Let's go through this again. And so we are over here, we're going into the marking process of pterygium surgery. And if we go back on this, the placement of the speculum and draping, then the limbal corneal traction suture, did you put it appropriately? Marking the site of conjunctival incision with a graft incision. And this is very important. The next is dissection of the head and body. You can see you're holding with the forceps and then disassembling the different parts of the pterygium. So what are the different steps which are observed in this? Excision of the head performs partial removal, or if he's an expert, he removes completely and he does it very fast and effectively without sort of leaving any residue. And superficial keratectomy, he's not aware of the procedure. He's competent in which he's near perfect, but if he's perfect, then he goes on to an expert. Then you go on to dissection of the base. So you're going to the base of the pterygium and seeing what parts of the pterygium he can remove that. Then you can graft dissection using subconjunctival fluid, conjunctival resection, and dissection of the pterygium body. If he cuts it very easily and it's appropriate size, perfect, then it's an excellent. But he has difficulty even identifying different parts of the pterygium, then he is a novice and he needs to come back. And then the other is dissection of the tenon capsules and removal of the 2 millimeter strip from the conjunctiva. Then it's scleral shaving and cauterization. So if he's a beginner, he has a moderate difficulty to establish between conjunctiva and tenon capsule and produces damage to the conjunctiva. So he needs to be going on to the next level. And so similarly, scleral shaving. If he achieves good scleral smoothness, adequate cauterization in intensity and localization, then he's competent. Then we go on to the next part, which is the graft. Either use a conjunctival graft or you can use an amniotic graft, and then you can apply mitomycin. So if it's not applicable, then you can say that this is not applicable. You can leave that because every time you might not be using mitomycin. Then not aware of indication, then if he's an expert, then he's aware of indication, good management. And then conjunctival flap, graft present. If he measures the graft size and obtains adequate size, then he's excellent. Then stitching the graft, placing the graft that places the graft 1 millimeter from the limbus, matching the limbal graft area with the limbal area. So he's good at sizing. So if the graft is too away from the limbus and it's small in size, then obviously it might be a beginner or novice. Then if he uses the conjunctival flap or a graft, then we've got a different step for a flap. And then you go on to global indices, which I said are tissue handling. If he's excessively aggressive or timid manipulating tissue, is a beginner. But by eye positioning of the pupil is kept right in the center during the surgery, then he's an expert, which is, I think, quite difficult thing to do even for experts, especially when you check your recording, you can see that always tends to move away. Then techniques of surgical knot, he's unable to tie, then he's a novice, and he's able to tie a flat knot, not first throw, but second and third throws are inefficient, then he might be a competent person. Handling instruments are not selected according to what is used. And if he's properly selecting for each procedure, handled properly, effectively, then obviously he is an expert. Then communication with the surgical team, knows role of each member and treats them with respect, establishes good working relationship, and effectively requests instrument from the scrub nurse, because that is very important. Because when you're looking under the microscope, you do not move your head to the side and say, give me this forceps. You just say, give me suture tying forceps, and she puts in your hand in the right direction, so you don't have to fumble with it. You just go in and do the surgery. So in conclusion, the OSKAR for pterygium surgery has a good face validity and can be used effectively for both teaching and assessing ophthalmology residents and in training programs across the world. So I encourage you to use this tool, and please give feedback if you find it useful or if there are any improvements which can be done. Thank you very much for watching.